Good afternoon, everyone, and thank you for joining us today to discuss this important connection between sleep and the health of your heart. My name is Dave Miglin of Strategic America, and I will be acting as moderator for today's webinar. Dr. Stephen B. Grant of Iowa Sleep will be sharing his insights about this topic, as well as answering as many of your questions as possible after this presentation is completed. If at any time during this presentation you would like to submit a question, please feel free to do so by entering it within the chat box of the GoToMeeting webinar sidebar, or simply email us at info@iowasleep.com. And now it's my pleasure to introduce Dr. Stephen Grant of Iowa Sleep.
Good afternoon. Welcome to our webinar today. Before I get started, I just thought I'd spend a second orienting people to exactly what we're speaking to, which is really breathing and circulation. And pursuant to that, on this slide, you'll see a picture of the heart and lungs in situ in the body. This is going to deal with a main theme here for today's presentation. And one way to conceptualize this is that the heart and lungs work together as a team to keep us alive. Looking at this a little bit further, the heart, there's a cartoon up here of the heart in situ in the body that shows what the right and left side are respective to one another. First and foremost, the heart is best considered as a pump. I like to think of it as a pump that's divided into two specific sides. The right side of the heart is connected to the lungs. It takes blood that is used to the lungs to be cleaned. The left side of the heart takes blood from the lungs to be pumped to the systemic circulation. Speaking more to the lungs in particular, this is the site of gas exchange. The lungs are critical in essentially cleaning blood. Carbon dioxide is taken from the blood and oxygen is introduced into the blood. Essentially, the lungs need the heart to bring used blood for cleaning. Then the lungs return fresh blood back to the heart for the body's circulation. In a more specific sense, this gas exchange happens at the distal segments of the lung in an area known as the alveolus. This is where carbon dioxide is taken out and oxygen is put into the blood. So our lungs work when we're awake. We know that when we're talking and moving around, we're breathing, but this also is the case that when we sleep, our lungs work in a more automatic sense. There's a trigger system, a pacemaker in the brain that fires the lungs when we sleep. This cartoon illustrates on the left side inhalation. We have the diaphragm that pulls down, generating a negative intrathoracic pressure so that air is taken in the lung. And on the right side of the slide, you'll see the active exhalation, which is where the diaphragm pitches up. There is positive pressure in the lungs and air is expelled. And the whole concept here on the left side is that inhalation is where oxygen intake happens, and on the right side, exhalation is where carbon dioxide excretion happens. So let's talk for a minute, if you will, about sleep. We all know that sleep is good. It's something that I personally enjoy myself, both personally and professionally. Sleep essentially is a state of anabolic metabolism. It helps our body recharge. There are some normal physiologic phenomena that happen in sleep. We know that during sleep, we can see the heart rate decrease. This is normal. We also see normal falls in blood pressure. Essentially, our body is in an exceptionally relaxed state. We also know that stress hormones are low. And again, this is a time of building and repair for our bodies. I'm often asked questions about why we sleep. And I think these two quotes at the bottom of the slide serve as bookends, if you will, for our current understanding in the science of sleep about why we sleep. The top quote is from Dr. William Dement, a very famous researcher in sleep medicine, and I really enjoyed this quote. As far as I know, the only reason we need to sleep is that the really solid reason is that we get very sleepy. And that's a little bit of a tongue-in-cheek statement that's contrasted with another observation from Dr. Paul Shaw at Washington University that states if sleep is truly unnecessary, it's the biggest mistake evolution has ever made. So what happens when we have obstructive sleep apnea and our sleep quality? Well, first and foremost, sleep is fragmented. As I said before, Normal sleep helps the body to relax and build, but when sleep is fragmented, you'll see that the body is stressed. I spoke to the positive physiologic changes that happen in normal sleep, where you have a decrease in heart rate and a decrease in blood pressure. In people with obstructive sleep apnea, this phenomenology is turned on its head. It's 180 degrees. Their heart rate is increased and their blood pressure is increased. We also know from an observational standpoint, breathing is irregular, it is generally not deep enough, and ventilation is clearly impaired. Looking at sleep apnea's impact, this is truly an upstream phenomenon if you want to think about it. The cartoon on the right shows normal breathing during sleep. And if you can see the blue arrows, it shows air transiting through the nose and through the mouth, past the tongue, to the back of the throat, into the trachea. Well, when somebody has obstructive sleep apnea, it's a little bit more difficult. That airway is blocked, and this blowout cartoon shows that the normal blue arrow now isn't flowing past the tongue in the back of the throat into the trachea. The airway is blocked. There's a choke point. And essentially, what this means is that there's a dramatic reduction or a cessation of gas exchange. People aren't breathing or ventilating. This next slide shows some more cartoons that demonstrate this. It might be a little bit difficult to visualize, but at the bottom of the slide, there's a picture of an individual facing up. Again, this is another way to conceptualize airflow through the nose and mouth. On the left side, through a patent or open airway, there's ventilation, but on the right side, you can see that clear choke point. Some of the symptoms of obstructive sleep apnea that we often hear about are individuals that suffer with loud, disruptive snoring. Sometimes bed partners can talk about witnessed apneas or periods where people are not breathing. The patients themselves can have troubles with just generally non restorative sleep. They can wake up in the morning feeling just as tired as when they went to bed, as well as struggling throughout their day with excessive daytime sleepiness. And speaking about sleepiness, this is something that can be a little bit difficult to subjectively measure. This is an instrument we use in sleep called the Epworth Sleepiness Scale. In brief, it's kind of like a Likert scale that you fill out. There are 8 questions, and if you can see on the script, it's different scenarios that people may find themselves in. So you're to read the scenario and then rate your proclivity or whether you would doze or not. So 0 would mean I would never fall asleep. 1 is a slight chance of dozing. A score of 2 is a moderate chance of dozing. And a score of 3 is a very high chance of dozing. So you fill out or score each of those 8 scenarios, sum them, and your score over 24 represents your sleepiness scale. For those of you in the audience, if you can take some quick notes and do this, a score of over 11 gets my attention, and I think certainly heralds an examination of your sleep. A score of over 18 is exceptionally concerning to me, and in my clinical opinion, denotes pathologic sleepiness. So, talking about sleep apnea a bit, I often hear patients say, well, I don't stop breathing at night, but that's kind of an incomplete definition of what sleep apnea is. We actually look at 2 different distinct forms of breathing that people can suffer with obstructive sleep apnea. Nia, the Latin word for air, and speaking about different descriptions of sleep disorder breathing, apnea is not breathing, ania. In other words, that's effort at breathing, but no ventilation, no flow. And then we also talk about hypopneas. Again, nia meaning air, hypo meaning low. Those are low tidal volumes or low breathing events, not breathing deep enough. Essentially, these 2 types of breathing patterns are what define obstructive sleep apnea. And from a cause and effect standpoint, anytime you have impaired breathing, you have the lungs that can get confused because they're not ventilating. You see low levels of oxygen, high levels of carbon dioxide. And essentially, if you remember back to the first slide that I showed, the heart and lungs are intimately connected. So if the lungs are getting confused, the heart gets confused, and there can be some clear physiologic consequences because of this. Looking at problems in the heart, I like to describe this as more of as quote unquote electrical problems, or in medicine, what we call arrhythmias. And there are 2 specific arrhythmias that give me pause. One is atrial fibrillation, otherwise known as AFib. and the other is supraventricular tachycardia, otherwise known as SVT. I think some of the audience may be familiar with AFib. It's essentially where the top and bottom of the heart are not in sync. In other words, the atria are not firing in sequence with the ventricles. And as I said before, I think of the heart as a pump. And right now, in patients with atrial fibrillation, this pump is not very efficient. There's a lack of sequencing of blood through the pump. Speaking to supraventricular tachycardia, this is a phenomenon where essentially the pump is just working too quickly. In other words, there's not enough time in the heartbeat for the heart to relax and fill with blood and deliver blood to the systemic circulation. For a better term, the pump does not have enough time to fill. In other words, it's not primed. Some of the consequences: patients with atrial fibrillation will often describe a multitude of symptoms. Sometimes they'll be very aware of their atrial fibrillation, sometimes not. People that are fib aware can describe a feeling of a fish kind of flopping around in their chest, is how they describe it. They can also describe shortness of breath. They can also describe a prominent decrease in their exercise capacity. This can be described as problems with either walking longer distances or climbing stairs. Sometimes they can just generally feel weak or unwell. And one of the real concerns with atrial fibrillation is the risk of stroke. Speaking to supraventricular tachycardia, that's a very concerning rhythm and can drop people. Some patients with supraventricular tachycardia or SVT do describe chest pain or pressure. There's a very high potential for heart attack. And these are the patients that sometimes end up with defibrillators implanted in them by physicians to prevent this arrhythmia from happening.